It's Reefer Madness, the podcast with Trevor and Kirk.
All right, Kirk, we're back.
Hey, Trevor, how's it going?
Really good. So you had some interesting conversations lately, and this one, hope I'm saying it right, Dr. Johannes Thrul.
Yes, correct. I was trying to sit here and remember how did I find him, and I can't remember.
Sure.
Sorry, but
You're getting old.
oh well, yeah, that is a problem. I do have that limited memory thing going. But no, I was listening to a podcast, I think, and his name came up or the study came up. And I reached out and they immediately got back to us. Um, and I was having a conversation with him over, like, sort of with Dr. Glad that you had, Vlad, that you discussed
Lad.
this. Yeah, within a day and a half, I had the interviewer lined up. So I mean, I sent out an email. He said, "Yeah, I want to talk to you." We set a date all within 3 days. So I had his voice in our library waiting for us to talk about him within 3 days of meeting him. And that doesn't usually doesn't happen that fast. It usually requires a lot
No,
of waiting.
no, that worked great. So I know you guys talked about other things, but let's just sort of mention off the top. The main thing we're talking with him about is the Cannabis and Health Research Initiative. Do you
Correct.
want to talk a little bit about that now?
Well, we should introduce ourselves first since we always seem to forget to do that.
All right, all right, all right. Fair enough. Trevor Shutefeld, I'm the pharmacist.
And I'm Kirk Nankers. I'm the registered nurse, and you have found Reefer Medness, the podcast. And if you're listening to this, you realize we got over 170 episodes. You can find us at reefermed.ca. Basically, Trevor and I, about 8, 9 years ago, said to each other, let's learn more about cannabis, and let's do it by talking to people from around the world. And I now remember how I met this gentleman. I was reading a paper about cannabis use and cannabis use disorder, and I was trying to get a hold of the authors. And the only two emails I had was I think it was Dr. Nicholson and Dr. Thrall, and Nicholson wasn't available, so he passed me off to Thrall, and Thrall got to me. That's how I found him. So I found him
Because
in.
because the listeners need to know exactly how the email chain went.
Oh, sure, of course, because how do we find people when we live in Dauphin, Manitoba, Canada, pretty much the center of the province or the country. But so, anyways, yeah. So what I discovered is that this guy belongs to a team of other researchers that are trying to set up a national database of medical cannabis users with the hope that they can have a library that they can distill out to people on cannabis. It's a fascinating story, National Cannabis Study that they're doing, and their hope to gather information about medical cannabis from around America and the world. So that's basically the story. We did talk a little bit about the study, the adolescent chronic use of cannabis use disorder by cord, and you have to accept it.
Yep, you got it.
All right, I got one more thing I do here. You said that you sometimes record yourself. You have your own mic?
Well, I mean, only because, ever since the pandemic, obviously everything has
Yeah.
moved so much to a virtual and hybrid and what have you. And so I figured at some point it's a service to my colleagues because I'm on Zoom calls every day, all day, that,
Yes.
at least I can invest in a decent microphone to have my voice come through
Yeah, we started this
better than it otherwise
podcast.
would.
We started this podcast 8 years ago, and we went through the pandemic, and it changed everything. And now everything's by Zoom, and we're reaching across the world. Thank you so much. We're on record now. So I guess, sir, I usually start by asking my guests to introduce themselves, give me a short narrative of who you are and how cannabis came into your life, and then we'll get into the discussions.
Great. Thank you for having me. My name is Dr. Johannes Thrul. I'm an associate professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. I'm a psychologist by training and have pretty much spent my entire career investigating substance use and increasingly behavioral addictions as well. And my niche, my intersection is with digital technology. And so I use a lot of technology methods to understand substance use behavior, develop interventions, test interventions.
Okay.
I would say that's about me. Yeah.
Are you mostly a clinician? Are you a clinician or a researcher, or have you done both?
I don't see patients.
Okay.
I spend all of my time doing research and teaching and university service, but I would say predominantly my time goes toward research.
Sure. But in some point of your practice, how long have you at some point in your practice, were you a clinician? Were you working with clients?
Yeah, so I was never a registered clinician. I did my training in Germany. And in Germany at the time, there were kind of two paths where the PhD is a degree in research that is not really, clinical training is not part of that. It's a route that you have to pursue in addition. I was always interested in clinical work, but I guess I was never interested enough to spend the substantial amount of time that is required to get licensed, knowing that I probably wouldn't want to work clinically. Or rather, I think the trade-off was always maybe I was just always more excited about spending my time doing research rather than spending the time doing clinical work. With that being said, I've done internships. I've worked in hospital settings. I've gotten clinical training. I spent a lot of my time in grad school doing my master's in clinical, getting trained in clinical psychology. And then I do clinical trials, kind of behavioral interventions. So in that context, sometimes I will deliver intervention content and have conversations with patients, with study participants, but clinical work is not part of my day-to-day.
Okay. No, that's cool. I've been nursing 45 years, and sometimes I've said I love nursing, but sometimes the patients just get in the way, So I understand the dilemma. I get it. And this is what I'm doing now is I'm really spending a lot of time researching cannabis opposed to working with cannabis. And a lot of it has to do with I find books sometimes more entertaining. So let's talk about so where did cannabis come into your life then? How did that intersect? Because we're going to get into your relationship with the Cannabis Health Research Initiative, but how did you get the cannabis?
Yeah, so I would say just based on my upbringing, I grew up in Germany, in rural Bavaria, and cannabis was around when I was growing up. And so I've seen some, folks develop what I would say pretty problematic relationships with cannabis early on, and then other folks were completely fine. And so in that sense, it's been kind of around me growing up. But then professionally, in my graduate work, I became interested in prevention, really. I became maybe a bit disillusioned with the clinical model of treating mental disorders after the fact and wanted to do my PhD work on prevention. And at the time in Germany, when I was looking for PhD positions, and I was looking for prevention. Most of the prevention that was funded at the time was substance use prevention. So that was my entry point into substance use. And I started working on mostly tobacco, worked on a clinical trial for a smoking cessation intervention for teenagers. And that way was kind of my entry point into substance use and addiction research. Incredibly fascinating. It's what I feel like I want to do for the rest of my life. But so starting with tobacco, but then when you actually start digging deeper into substance use patterns and behaviors, you quickly realize that we have maybe constructed silos of substance use, of like we're either looking at tobacco, we're looking at alcohol, we're looking at cannabis, but frequently a lot of what's going on is substance co-use in the real world. People are using multiple substances. They use substances to modify their experience, and they use whatever kind of substances are available to them based on what they want in the situation in the moment, right? And so in that sense, I became interested in all kinds of substances that young people use, including cannabis.
Cool. You know what? I'm changing. I'm pivoting. I said to you, we're going to start with the database. Let's go right into the paper, and I'll explain to people. I'll explain to the audience how I got here. So let's talk about your paper, and let's talk a little bit about addictions because my background. 45 years a nurse. I've been emergency OR. I've been a specialist in most of my career, usually in a rural environment. The last 15 years, I had a wonderful opportunity to work in First Nations reserves. And in Canada, our reserves are fly-in. We're very remote. I mean, I'm sometimes operating on a diesel generator, and and when the reserve runs out of diesel, you got nothing, right? So I've had as a primary care practitioner, I'm not a prescriber. I am a registered nurse, but gosh, man, I would probably say 60 to 70% of my clients had some form of addiction. And that could be whatever. And I guess, can you speak a little bit about that? Because one thing that bothers me about tobacco addiction is how it's orchestrated, how big tobacco orchestrated that whole process. And part of tobacco is to addict you. But what is the difference between tobacco addiction or tobacco misuse? I like that better. Or alcohol misuse and cannabis misuse. Can you explain to me what the difference of those disorders are?
Yeah, so the main difference I would say is just the substance that is involved, right? I mean, for tobacco, maybe we wouldn't say tobacco is not intoxicating. So you wouldn't have that kind of acute harm intoxication, like, somebody gets drunk, climbs on a ladder, falls down the ladder, has an acute injury, or driving is a good example, right?
Yes.
Driving under the influence. So with tobacco, you wouldn't necessarily have that. But if we're looking at just substance use disorders broadly, like what does that mean to us? In general, my kind of lay interpretation is always it's continued use despite negative consequences. So people have serious impairment and consequences in their life because of their substance use that they know about, but they're unable to stop, right? And so that goes along with loss of control, craving, withdrawal when they try to stop or are in a situation where they can't use, tolerance that they have to use more and more to get the desired effects, and then the negative consequences in maybe their professional life, in their social context, in their hobbies, what have you, right? So continued use despite negative consequences and this kind of loss of control over use.
Can somebody be functional while being considered misusing? Like, is a person not competent to be a disorder or functional? Like, how does that work?
Yeah, so based on the way we give a diagnosis is based on, in the US, on the DSM,
Yes.
DSM-5, and the DSM goes through, essentially it's a checklist, right? So it looks like in the past 12 months, have you had fulfilled any of these criteria? And then if you meet two or more, then you get a diagnosis. Obviously there's a range, right? You can meet two, you can meet more than two. So there's a gradation there. It doesn't really say like whether or not you're completely functional or not functional as a member of society. So I would say there's still a gradation that doesn't really go into, I mean, there's severity, obviously. So you would assume that somebody who has a more severe substance use disorder is more impaired. So I think there's no one good answer to that question other than that it's not the way we give a diagnosis is a yes, no. You can have a substance use disorder or not, but then when you have it doesn't mean that it's all the same experience, right? People can then still be on a spectrum of more or less impacted, impaired, negative consequences due to the disorder.
Okay. I got a couple questions. I guess I'm going to just take a step sideways for a minute. When somebody misuses a substance, in your research, your personal belief, do you view them as losing control of their behavior, or are they ultimately always in control? And the reason why I say that, because there's really two types of therapies, right? There's the AA model where you put your hands in the Lord and God, you follow God, and and one day at a time. And then there's the philosophy that basically you're responsible for your behaviors. We need to show you how to correct these behaviors. So is there, from your perspective, when someone has a disorder, are they ultimately in control of themselves, or are they lost control because of the substance? Does that make sense? Is that a logic?
Yeah. I'm just trying to see, I'm trying to figure out how to best respond to this. I would say, as with the previous question, there's no clearly yes or no answer. I think for the treatment models, I think that just, certain treatment models resonate more with one person versus another. I've seen 12-step approaches work really well for people. There's good evidence. And for other people, the idea of this higher power doesn't resonate, and they're looking for something different, right?
Okay.
So, harm reduction is maybe a different approach where the goal isn't complete abstinence from intoxicating substances, but the goal is to reduce the negative consequences due to substance use by whatever the means necessary. And it's maybe more of a treatment person fit kind of question, I would say. And loss of control, again, I think it's a very subjective thing. Yeah.
No, I appreciate that answer. And the reason I'm asking is because I'm trying to put myself back in my nursing room when I have a client coming in, and I'm very much the harm reduction guy, and it's a lot of the care mapping I was following was that the care mapping didn't necessarily agree with my approach to how I would approach the patient. So I appreciate that response, because one thing Western medicine doesn't always allow, it doesn't allow for individualized care. We seem to care map, and insurance programs tend to fund for care mapping. So I just thought I'd ask. So let's jump into this study. I got one of my documents here. The name of the study, now where did I put it? Here it is. The Adolescent and Cannabis Use Disorder Study, the association of cannabis use disorder versus other substance use disorders with psychiatric conditions and a propensity to match retrospective cohort. Can you explain this study for me? What were you trying to accomplish with this? What was your thesis statement when you started it?
Yeah, so before I get into the study, I'll just say that this is the work primarily driven by Dr. Ryan Nicholson and Dr. Una Choi. Ryan was a master's student getting an MPH at the Bloomberg School, and this was initiated as his master's capstone project that I was his advisor on.
Okay.
And he's now a medical resident here at Hopkins in anesthesiology. So the goal of this was to investigate the risk of developing different psychiatric conditions by substance use disorder exposure. So does a certain substance use disorder lead to other mental disorders, psychiatric disorders, with a large sample of electronic health records across the US. So we used Trinetics data, which is an aggregator of electronic health records across many institutions in the US and I believe internationally. For this study, we used US data.
Okay. And are you familiar with the Kaiser study where they were saying that cannabis can cause double the chances of psychosis developing in a young brain? Are you familiar with that study?
Um, there's a chance I've seen it,
Okay.
but I don't, yeah, not the specific study does not come to mind.
Okay, fair enough. And I appreciate the fact that you're an advisor in this. I get it. I was trying to get the author when he went to you, and then I found another story for you. But when we again looking at this paper, um, is there a concern? The thing that I wrestle with is the lack of understanding of cannabis in Western medicine. And if a young child, I mean, at 15 years old, if my mom and dad had taken me into the doctor at the time, I'm sure if they had that diagnosis, I would have been caused a cannabis use disorder kid because, I mean, I discovered alcohol was not good for me. I was a very bad drunk as a teenager, so I turned to cannabis, and I found cannabis much easier and softer for me. So when we look at young kids, how do we determine who's determining that these children have cannabis use disorder? I know you go through the tick sheet, but is it a fair diagnosis? Do you believe that they're fair diagnoses? Do physicians know enough to label somebody with authority that they have cannabis use disorder? Is there flaws in that?
Yeah, so with a data set like this, obviously it's very difficult to speak to everybody who landed in the data set and how the diagnoses were made. In general, I think, providers are probably fairly competent in making those diagnoses. Now, I can't really speak to every single case here. But I would say in general, if you follow the DSM, right, to its definition, then we would assume that these folks are using cannabis to an extent that causes them negative consequences in their
Okay,
life.
that's
Now,
fair.
how nuanced that is in every case is hard to say.
Okay. Trevor and I can discuss the results. I'll get into your, but I guess one question is just one question more on this study. How would you apply this study clinically? What would be your recommendation to clinicians who read your paper and say, "Oh my goodness, look at that. People with cannabis use disorder have doubled the threat of doing the psychosis." So how do we apply it clinically?
Yeah, I would say it's a call for screening and early intervention as much as possible because we know that there is a particular risk window for development of negative consequences for cannabis use. As you know, right, the brain is still undergoing pretty substantial changes up until maybe the mid-20s or so. And there seems to be maybe heightened risk in adolescence before the brain maturation is finished with cannabis exposure.
Hmm.
Now, what's tricky here is there's some assumptions you have to make here with cannabis use disorder that presumably most of these folks are going to be using THC dominant products, right? That THC is driving this. You wouldn't necessarily get CBD. People don't experience this reinforcing. Obviously, there are other cannabinoids now in the US. There are more and more minor cannabinoids that are part of the products. But just because these data are, it's always historic, right? Like we're dealing with data always from the reflection of the past. And the market differentiated recently with a lot more different products being available. Now for teenagers, not so much, right? Because there's age restrictions and you can just walk into a dispensary and buy a product. But we would assume that THC is driving those effects. And so early exposure to THC in a developing brain seems to be a risky endeavor.
Brilliant. Brilliant answer. I completely agree with you. again, clinically, one of the things that bothers me is how cannabis as a plant is always the problem. Cannabis use disorder, cannabis this, cannabis that. And it's like saying, well, we don't talk about barley that way. I mean, barley produces alcohol. We don't, we don't blame the barley plant. So I'm Trevor and I have this ongoing debate about, cannabis overdose. Well, I don't believe somebody cannabis overdoses because as an emergency nurse, ABC's antidote. If you come in and say I've overdosed, I want to know what you overdosed on, and I want to know if I need an antidote. Cannabis overdose isn't a true term. It should be you use too much THC. And as one of my guests said, well, that's not a sexy way to describe it. Cannabis overdose is just so easy, but you took too much THC takes too long to say. So I completely agree with that answer. That's I think that's a good answer. Let's segue.
Yeah, I mean, overdose is also tricky because you're not really dealing with if you're overdosing on opioids, if you're overdosing on alcohol, right? We would be very acutely concerned with loss of life.
The brainstem.
THC,
you're looking at the brainstem, right? Yeah.
Right. At like really core bodily functions. Like, are you still able to breathe, for example? With cannabis, it doesn't look like that. It's not that people, who overdo it on cannabis acutely aren't in for a rough time. They can be in for a very rough time. But we wouldn't be concerned about acute loss of life because of the shutdown of bodily functions.
So help me out here. If you and I were going to change the world, how would we describe the cannabis overdose? What would be the best way to say to a clinician, they haven't cannabis overdose, they have, what have they done?
Yeah, I would probably acute intoxication.
From THC.
Hard to know. Obviously, now in the US, right, it could be Delta 8, for example.
Oh gosh,
right?
Yes,
It could be,
yes.
yeah. So it's gotten a bit more tricky. But in general, I would assume we're dealing with the consequences of an intoxicating cannabinoid. More likely than not, that's still going to be Delta 9 THC. But the marketplace has gotten more complicated.
Yeah. We spent some time I spent some time in Spain, and they're selling hemp products out the front door, but it's Delta 8. And and it's a different. To be honest with you, I'm almost I'm almost scared to try it, because I'm very familiar with THC Delta 9, but what's the Delta 8 high like? And there's no effect on the endocannabinoid system. There's no different effect. It's just a different cannabinoid, from hemp.
Yeah, it tends to be, so it's synthesized from the hemp plant usually. If you're just taking a hemp plant, right, like you would have Delta 8 in relatively small concentrations. My understanding is also, I'm not a biochemist, right? So take this with a grain of salt, but that you can synthesize it from maybe CBD, but don't quote me on that.
Yeah,
But anyway, it's coming from the hemp plant, right? In one way or another, it's derived from the hemp plant. And the clinical studies that I'm familiar with, where they did kind of the comparison to look at pharmacokinetics, pharmacodynamics, it looks like roughly maybe 50%, half as potent as Delta 9 THC, with people are describing it, if you're looking at Reddit or survey data, what have you, people are describing it as maybe a little bit more of a mellow high with less of the maybe anxiety, paranoia, what people can experience with Delta 9 THC. Now, whether or not that's actually a property of Delta 8, other than that it's just not as potent, and people, if you doubled the dose of Delta 8 compared to Delta 9, you might be looking at fairly similar effects, but it's not as potent. So then if people are, taking the same dose of a Delta 8 as compared to Delta 9, they would experience obviously a more mellow effect.
Okay, very cool. All right, so let's go to something that you're more comfortable with, and I think you're extremely excited about from what I've heard on your other podcast. Let's talk about the Cannabis Health Research Initiative. Uh, Now, from what I understand, there's basically three components to this, right? There's the National Cannabis Survey, there's the repository of data, and then there's the research library. Where would you like to begin?
We can start with the National Cannabis Study.
Sure. Okay. Let's give me an overview of what that is for our listeners.
Yeah, so maybe I'll start even a bit broader if you don't mind.
Sure.
That this is a large project that my colleague, Dr. Ryan Vandre, here in the Department of Psychiatry at Johns Hopkins in the Behavioral Pharmacology Research Unit, and I are co-leading on a large team effort with folks here at Hopkins and then the Realm of Caring Foundation in Colorado. And this was, we wrote this project proposal in response to a request for applications from the National Institute on Drug Abuse that was asking for research to establish a medical cannabis research registry to investigate the health effects of medicinal cannabis. So this entire research program that, as you already mentioned, has multiple different components that we can get into is all in service of helping us build better evidence for the health effects of medicinal cannabis. May they be positive, absent, or negative. And we started getting into this a little bit and talking about different cannabinoids, right? I agree with you that at this point, the term cannabis is almost a misnomer because we're really dealing with many, many different cannabis products and cannabinoid products under the umbrella that we expect can have very different effects. And so one thing is the complexity of the products, of the active ingredients. The other thing is from behavioral pharmacology research, right? We know that route of administration matters. So whether or not you are smoking a product, you're inhaling a vaporized product, you're eating an edible, you're using a tincture, something topical, suppositories, what have you, we would assume that those have different effects just based on the route of administration. And then under the medicinal cannabis use, kind of when you're looking at the population, right, of folks who are using medicinal cannabis, they can use for all kinds of different reasons, different conditions, maybe multiple conditions. And when you then put all of those things together, the product ingredients, the routes of administration, the different conditions, you're dealing with an insane complexity that is very, very tricky to get a handle on scientifically. And so that's where we start, right? How can we start getting a handle on these things? And the goal is so the project includes approaches that collect new data of folks, that's the National Cannabis Study, of folks who are newly initiating medicinal cannabis use for all kinds of reasons. We really take all comers, and we follow them for a year. So what we're trying to do in this study is to get folks in the door right before they initiate, to have a baseline that is pre-initiation, because our assumption is that a lot of the changes that we might see will happen in that initial year. And if you're just taking a cross-sectional snapshot of medicinal cannabis users, you don't really know how long they've been using. They might have been using for years already. They've established a pattern that works for them. You're not going to pick up on any changes over time because, obviously they have arrived at a product, a dose, a pattern of use that works for them, presumably. And so the change that you would be able to pick up over time in the symptom burden, conditions, what have you, would be fairly minimal, I would argue. So that's why we're trying to get people in the door when they're interested in initiating use, but they have not initiated yet. So that's the prospective part of the study. And there are a couple of sub-studies to this that I don't really have to go into much detail, but we have sub-studies that use smartphone-based data collection on a subset of people around every assessment time point, where we're getting more detailed pre and post dosage data on pre and post cannabis exposure. We have a subset of folks that we invite to get biomarkers. We send them to a lab where they get blood draws. We can do clinical chemistry analysis on their bloods and get biomarkers. And so that's the prospective data collection. And then we're also working with large-scale electronic health records here at Hopkins to identify medicinal cannabis use in the electronic medical record. So the situation in the US is, and I'm not sure what it's like in Canada, maybe it's fairly similar, is that there's no checkbox to give folks a label of this is somebody who's using medicinal cannabis. It's not like, cannabis use disorder, what we talked about before, that gets coded in the electronic health record. Medicinal cannabis use does not. And so it's challenging to identify those types of patients, but if we could identify them, then we would all of a sudden have a whole wealth of data over time to look at health outcomes, right? You could look at healthcare utilization. You could look at changes in symptoms of disorders that they have just because of things that already get recorded in the electronic health record. When you see a doctor, then a bunch of tests are being done and things like that. And so the approach that we're taking with that work on electronic health records is in collaboration with some of our good colleagues in engineering and computer science to develop approaches that utilize AI large language models to go through those records and identify patients who are using medicinal cannabis based on provider notes. So that's, you can imagine, messy free text data that are inconsistent across providers, across clinics, to pull out the relevant information and flag patients if they are meeting certain criteria, right? We might see language around where a model is then relatively confident that this is somebody who's using cannabis for medicinal reasons. And that could be hemp, it could be THC dominant products, it could be different kinds of routes of administration. And once we can identify those folks, then we can start building these kind of studies where we compare and contrast folks who are matched based on, say, like sociodemographics and conditions that they have and are using medicinal cannabis versus not, to then look at their trajectory and the outcomes over time. So that's the work with the existing data. And then, as you already said, all of the data we have that we collect in the prospective survey will go into a repository that will be accessible for the research community, for nonprofit research. And once we have a decent number of data in there, then we'll open it up for folks to use. There will be a system in place where people can request the data. There'll be a pilot program to provide funding for junior investigators to get more people into the space. And we have a research library that has studies that we have gone through, and our team, and extracted relevant information and categorized the studies based on the relevance for this area of research. And then I'll say the last thing is, broadly speaking, I don't think that observational data will ever replace clinical trials. Clinical trials will still be important, but what these large-scale observational studies can show us is where are potential signals for the health effects of medicinal cannabis that we want to dive deeper into to inform clinical trials moving forward. Because currently, even if you wanted to test a certain cannabinoid for a certain condition, you'd be hard-pressed to find data to inform what kind of route of administration should you use, what kind of product with which cannabinoid, terpene, what have you, concentration, at what dose should you start. And so the goal of these large-scale observational studies are to kind of find where the signals are to then prioritize potentially which products to move into clinical trials moving forward.
Wow. That's a lot of information. I got a few questions just to unpack that. First of all, let's start. This is a huge database you're proposing. How far along are you in gathering this information?
Yeah, so we're at different stages based on for different sub-studies. For the prospective data collection, the National Cannabis Study, we're still relatively early on. So we built a pretty robust system that has, been put through the paces. With online research these days, it is non-trivial to set it up so it's well protected. Early last year, we were savagely attacked by a swarm of bots and probably humans in the loop that initially it was very easy to determine what is a bot response versus a real participant. But over time, they learn and get better, so it gets really tricky. So now we had to essentially re-engineer everything from scratch to build really robust security systems that now essentially requires folks provide an ID that gets checked against the facial biometrics to make sure that they're real participants, because we pay incentives for survey completion, which means that it becomes very interesting for people to scam research studies like that.
Sure.
And with large scale AI available to anyone and everyone, a lot of people who have an interest in getting into research studies like that. So that's kind of the trade-off we have to make. We have to be really diligent about protecting the data quality.
Fair enough, which leads me to the next question in Tombstone information. When I decide as a user to say, oh, look at this study, I can participate in this, what Tombstone information are you asking from the individuals? Are you taking zip codes, ethnicity, social terms of health? What information are you gathering about the individual besides their cannabis use?
Yeah, so at baseline, we're getting a lot of this type of information. Obviously, we want to know people's background. And then a lot of the measures we have, this is maybe something we haven't talked about yet, but we have suggested measures on the website as well. One that we developed ourselves, the Cannabis Use Questionnaire, that gets at really detailed cannabis use. We talk about what are the facets that are important, as in what are the ingredients of the product, what is the dose that people are using, what is the route of administration, frequency, quantity.
When you CQTs, you called them? Is that what it was?
CUQ.
Yeah.
CUQ. Cannabis Use Questionnaire. Yeah.
Cannabis use care. Okay. So yeah.
Very creative.
Yeah. But it sounds like you've standardized those questions so that anybody who's doing cannabis research can go to that standardized list of questions so the data is consistent. Is that one of the goals?
Yeah. So we're hoping that it will be a service to the field to help put out what we think are the important facets of cannabis use that we recommend folks to assess. Now, we've started talking about the changes in the marketplace, right? I don't think this is ever something that's static. So there will be new products on the market that maybe our current iteration of the instrument isn't capturing well. So the approach that we took is that, so I guess I should start by saying that this tool is available for folks to download off of our website in ready-to-go versions for RedCap, for Qualtrics, common survey systems, where you can just import it into your platform and run with it. You don't have to start programming from scratch, which took us months to do. But now, knowing that the marketplace is in flux, right? The products that are available today might not be the products that will be available tomorrow. So this questionnaire, the tool, has to evolve with time as well. So the approach that we took is that once folks want to download it, we ask them to register with an email address. So we have essentially a list of folks who have at some point at least downloaded and looked at the tool. Whether or not they're using it, I don't know, what can I say. But once we make updates to it, those updates will go out to everyone who has registered to download the tool.
So how
that,
deep
once
do you get then for personal information? Do you get the person's individual names? And I mean, obviously birth dates and zip codes would be helpful. But do you get down to, do I put my first and last name into this database?
This is not information that will be kept with the health information, right? So the data will be kept separate from identifiers. And then especially once the data will get analyzed or open to use by other folks, when people can request the data we have, those data will only ever be de-identified. So we will never share that kind of identifiers.
Sure. And I
we
guess
need some identifiers, obviously, to make sure that people are real persons and all of those things to begin with. But then, other than that, the health information relevant data will be kept separate from identifiers.
Well, I find it fascinating because as I was reading about your survey, and again, I'm sorry I'm keeping you longer than I said I would, but I hope you have the time. As I read through this stuff, I was saying, is there any other medical condition, pharmaceutical product that is trying to capture this? Like, does the MS Society in America have a big depository of information? Is this something new that you're doing here to grab NASH? And is it just focused on national or is it international? Like, it seems robust and new to me. I haven't seen this elsewhere.
Yeah, so currently it's focused on the US. Potentially we could expand to other places. Obviously, English-speaking countries would be relatively easy to do. No, products might be slightly different. I mean, Canada would be an obvious choice because of national legalization of recreational cannabis, pretty robust medical market, right? I think I would argue we're probably the first in the US, at least, to assess cannabis use exposure at the level of nuance that we do and at the scale, especially for medicinal cannabis. The goal is to get 10,000 patients into this thing.
But you're identifying recreational users as well, are you not? Like, if I choose to enter my name in this can I do it as a recreational user or just as a medical user?
Yeah, so I mean, we're essentially taking people by their word that they're using cannabis to deal with a medical condition problem that they have. Now, the definition of what medical or medicinal use is not, there's no one type of way to define it, right? Back in the day, maybe you could have taken whether or not somebody is registered through a medicinal cannabis use state program. They've talked to a provider, they've gotten what might be called quote unquote a medical cannabis card. But now in a state that is recreationally legal, you can just walk into the dispensary, buy a product, use it because you have a headache or what have you. You never talk to a provider. I would argue that person is a medicinal cannabis user, but they wouldn't ever show up in a state registered list of patients, right? I mean, you could walk into a CBD shop that is outside of the state system altogether and use CBD because you think it helps you with anxiety or with sleep or what have you. So that definition has gotten very tricky, and we do see in states that go from usually the transition of states is that cannabis is not legal at all, then they have a medical program, and then eventually they go to full recreational adult use legalization. That's kind of been the trajectory in, I'd say, most states. And once we see the transition from just a medical to a recreational use, then you see that the recreational market takes a big bite out of the medicinal market, that people just don't get a card anymore. They just go to the dispensary and get their product. Whether or not, and states are very different in how stringent they are in allowing for medicinal use, qualification. So there's no standard across the country. And so, whether or not people just want to get cannabis and they qualify because of some kind of condition, and it's really tricky to say, right? Not everybody will meet the same criteria.
Yeah.
But what we see is that once states come online with recreational use, then medicinal use tends to go down for one reason or another.
Well, and what's happening in America is quite different. What's happening in Canada? Our medical system is federal, but our provincial systems are. The provinces are responsible for Western medicine. So the provinces provide medicine to our citizens, and the federal government has nothing to do with the healthcare system except, the federal law that says we have universal healthcare, but it's managed by provinces. So I have a theory that, we've had medicinal cannabis in Canada for, well, since 1999 or 2001, depending on the Supreme Court. And I think this, that, cannabis has been legislated a medicine, not necessarily seen as medicine by the medical practitioners. But because cannabis is federally managed, now it's also federally managed recreational because we have a federal law called the Cannabis Act. So what I believe is happening is that they threw it onto the provinces. The provinces ignore it as medicine because they don't have to because it's federal law. And now the federal government's saying, well, now that we've made it recreational, just go get your medicine, quote unquote, from the rec shop. And of course, bud tenders have no clue on EMRs or stuff. And so I think it's way of government sort of pushing it away. Right. So you have it in the opposite way where the states are going medical and the federal government saying that it's unlawful. So but it's still cannabis, right? Is cannabis medicine or is it not? I like you, I believe anybody that has used cannabis is using it medicinally. And I say that because I declared to you early that I was a young teenager who really didn't understand alcohol, but alcohol was in my family's room. Everyone, dad would have his martini and mom would have, and then I got into alcohol as a young man and really it was not good for me. And I discovered cannabis and went, this is different. So was I moving to cannabis as a medicine in those days, right? So I understand it's what makes cannabis so interesting.
Yeah.
One question on the data, and then I'll sum this up. The data repository, that is when you're asking people to submit their records, right? I know some states are collecting information on medical cannabis. So are you getting good response from other practitioners that are giving you their information?
Yeah, it's a big tent approach we're doing here is to reach out to folks and really anyone who has relevant data sets to contribute. There is a process that we have set up with our IRB here at Hopkins to govern essentially, data use agreements and transfer agreements that folks can collaborate with us and deposit their data into our repository. Because a lot of the time, if you live in the kind of soft money research world, you run a study, you collect data, you maybe get your primary paper out, and then a lot of the time you just have to move on to the next thing. And then there's still a data set that has a lot of value potentially, especially when you can potentially combine it with other data sets that then out of a sudden allows for analyses with much larger sample sizes, right? Where you might be getting to a meaningful number of folks with conditions that we wouldn't see in like a one-off survey, or we'd only see like a handful of folks for specific conditions that are not as common as chronic pain, anxiety, PTSD, insomnia, like the big ones that you see in all of the surveys, but where cannabis maybe has potentially a lot of promise. And so by combining data sets and harmonizing in a repository like this, we could potentially make a meaningful contribution to improving the data quality and the sample size that is available to get after these questions.
Completely agree with you, sir. Completely agree with you. Are you getting a good response? Are people responding to you? Are they saying, yeah, we'll share this stuff with you? Is it happening?
Yeah.
Cool.
Yeah, for sure.
Cool. And then eventually,
but we always, we're always interested in more, obviously. If folks are interested, yeah.
Now, did I read someplace that you're accepting international databases for that response? So if somebody in Canada had information, you're accepting international data repository, whereas the national survey right now is strictly
it's
American.
Just in the US. Yeah.
And are you US, sorry. And are you also eventually going to all that's going to jive and become the library?
Right. So the library is just papers, but the repository potentially, this is kind of, we have to see a little bit as we go based on what kind of measures are collected in individual data sets. Is there potential to harmonize across data sets? By harmonize, we mean, this study collected insomnia in this way, and this study, another study, maybe in another way. Is there a potential to kind of combine these measures? For some studies, some data sets, I think that will be an option. For others, maybe not so much. It depends a little bit on what we see in the data that we actually receive. The other thing I will say is that we talked about the cannabis use questionnaire that we have on the website. We also have a suggested list of assessments for health outcomes or health aspects around cannabis use that we suggest folks use in studies on medicinal cannabis. We call that the CABC, so the Cannabis Assessment Battery. And that is also on the website for download, so people can see, core assessment battery for cannabis. That what are the measures that we recommend for the field to use. And this is also a step in that direction of might make it easier moving forward to harmonize across different studies and across different data sets. If some of those measures are used consistently across studies, right? Obviously, it will become much, much easier to then build larger and larger data sets to get at where the signals are on cannabis use and health.
And when do you feel it's going to be accessible? Where are you and the timelines that you're going to say, hey, we got the information, it's now accessible? And you did say it was a year-long study. So is this something that will make, I guess funding determines this, but is it going to be an ongoing thing and progress as long as funding's there?
That's our goal. Yeah, that's certainly our goal, is to keep this thing alive for as long as we can.
It's a huge project.
Get more data in and build something that can be really useful to folks in the space and to the field.
Well, and as we said right up front, cannabis is such a misunderstood substance. And I think from what I've heard from other things I've read, and Trevor and I will fill in the blanks of stuff, but I think it's really quite cool. Is there any question I didn't ask you? Is there any information that you would like to share that I didn't get into?
I think we've all covered it. I would just say we're a very collaborative group, and if folks have an interest in working with us, in contributing to the repository, in using the measures that we have developed, just an open invitation for folks to reach out. And maybe potentially even the platform that we've built, if someone says, like, I want to run a study on a specific patient population and could funnel them through our platform, collect the data will go into a repository anyway, right? Mm-hmm. That's always an option as well. We maybe don't all have to reinvent the wheel for new studies. If this platform meets your needs, we're also super happy in collaborating.
I think you're being change agents. I think it's fantastic. And I also noted that one of your members on your team is from Alberta, and she's a alumni of mine, the University of Alberta. So when I was listening to her, it got a Canadian involved too. That's very cool. Actually, if you could pass word off to her that as a Canadian, I'd like to increase my Canadian content. If she would like to talk to us at all about her cannabis research, that'd be fantastic.
Yeah, for sure.
All right, sir.
I'll be happy to make that connection.
Yeah, thank you very much for this. This has been enjoyable, and I do appreciate your time. I'm sorry I took you over what I promised. My camera just broke, so I don't know if you've noticed, but I've been leaning here. My camera just broke off of my computer, so.
I guess that's the sign that
that's the sign that
the camera has decided this is enough.
Yeah. Again, sir, thank you so much. Probably looking at 6 to 8 weeks. This will be 2 episodes. Yeah, I'll let you go. I got to figure out how to fix my camera.
Good luck with that. And thanks for having me.
Cheers.
Bye.
All right. So, Kirk, I'd like to summarize stuff to see if I'm understanding what I'm listening to. So here's how I understand this sort of 3-part, we'll call it database. So the first chunk is the National Cannabis Survey. So it's an actual firsthand asking people, hopefully before they've started using cannabis for their medical condition, asking them a bunch of questions, your age, sex, whatever, what kind of cannabis you're using. And then hopefully after they've used it for a while for whatever condition, did it work? So that's kind of the National Cannabis Survey. Part 2 is a database repository. So this is info, secondhand info from other studies, maybe insurance companies, maybe practitioner notes, but a bunch of data that's been de-identified, so you don't know who the patients were, and dumped into a big data pile that can be queried. And then their work on things like data collection, standardized data collection tools, and ways to integrate all these various bits of data together. And then the third thing, a research library of actually published Canvas papers. And I was just flipping through that this morning, and I think there's 100 years of podcast ideas and research just in there. It was 3,000 plus papers just in that third part. So yeah, this is big and interesting and exciting. And do you think I sort of got the summary half-ass right?
No, you nailed it, and that's what I stumbled into when he responded to my original emails. I went in and said, "Okay, who are you?" And wow, look at what these guys are doing. The intent is to build a platform of data collection that they can basically have a repository of cannabis information. It's fascinating, and I kept trying to ask myself, and I don't think any other database like this exists. Like EMRs, like electronic patient records, are just now starting to come up. I mean, I can remember in the 90s, I had a very progressive family doc, Dr. Lindsay, Peter Lindsay. He has passed since, but Dr. Peter Lindsay was a very progressive family doctor. He liked technology. The man just loved technology. And he moved from Lac-La-Biche to Grand Prairie. And I went to Grand Prairie to see if I could get some employment in Grand Prairie. And I met Peter and hadn't seen him for a while. Peter used to be my medical director when I was a paramedic professor a college professor for paramedics. Peter back in the 90s showed me his room, his computer, that was a electronic patient record, and it like revolutionary, right? That's 30 years ago. Peter was doing this. And then of course I moved to Manitoba. Manitoba's a little, I don't know, I don't want to say backwards, but slower. It doesn't catch up to Alberta in that sense. Didn't have the money.
Is fine.
Backwards is fine. But EMRs to this day are still limited. I mean, not a lot of places have EMRs. I think your clinic has an EMR.
We do, and we're trying to get too far. Yes, and I my whole career, I couldn't wait for them to have. Well, they've had electronic medical records, but of course, the part that affects me the most is they have electronically generated prescriptions now, which should have been the fantastic for all pharmacists everywhere. The famous, I can't read your writing, or what do they say, or which doctor signed this, should all be over now, right? Yes, but I didn't realize it introduces new problems. So the new problems being, if you write it down on a piece of paper, you don't pick a completely wrong drug. You might spell it wrong. I might not be able to read it, but if someone has high cholesterol, you wrote down a cholesterol medication. Well, now that they're picking their drugs from a drop-down menu, someone might have a cholesterol problem and they picked a birth control pill because it's so easy to pick something wrong off a drop-down menu. So that's annoyance number one. And annoyance number two is with written prescriptions, you would physically get that from your doctor and walk over to the pharmacy and hand it to me. Every so often, a couple times a month, especially coming from the emergency room to us, patients would lose that piece of paper between the emergency room and here, and now it's a big struggle to figure out where the hell it was. That should all be over with electronic medical records, right? Nope. Apparently, it is phenomenally difficult to hit the print button that goes to the pharmacy. Several times an hour am I trying to call up doctor's receptionist to see where in the ether this prescription is, because the print button wasn't hit properly to go to the pharmacy. It's just been lost in the ether. They can find it, but it's annoying. Patients come and assume I'm the idiot that I didn't get. The doctor said he sent it. It's not here. They didn't send it. And even worse is the hospital. The hospital has no idea how to send anything out of the hospital to somewhere else. And of course, when you call a hospital, you go through 14 different people till you get to the right person who might know where. Again, I guess the good news with electronic medical records, they'll eventually find it. But oh my goodness, I'm not trying to be a Luddite, but things went so much better when the doctor wrote it on a piece of paper and handed it to people. I don't care that I couldn't read it, at least I got it. All right, sorry. Rant over. Electronic medical records, you were saying?
Sorry, I was just having this flashback as you're talking to me about communicating with doctors, and it's always killed me how everyone else in the system must communicate and use proper language and are evaluated by how you communicate. But a doctor can come in and write something and scribble it, and you can't read it, so you phone them at 3 a.m. saying, "What is this? What have you written?" And you get in trouble for waking him up. Anyways, that's doctors in their communication. I mean, yeah, no, electronic records, right? So I've had 30 years of understanding that they're out there, right? And when I worked up north, the federal government, I think there was 2 nursing stations that were moving into EMRs. The whole point about EMRs is that EMRs are supposed to be able to make things easier, and you would hope they talk to each other. Like one of my biggest pet peeves in the healthcare system, and this is my rant, is that we are told everyone needs a family doctor. I don't believe everyone needs a family doctor. I don't think the most important relationship is between patient and doctor. I think the most important relationship is between citizen and government. So if I go to Alberta and I get sick, I should be able to walk into any physical doctor's office, but unfortunately they're private entrepreneurs, but I should be able to walk into a healthcare clinic. They should be able to call up my EMR and say, "Oh, here you are, Kirk. Here's your EMR that your doctor and Dauphin wrote out. And I can see that here's your, and carry on with my care." But the problem with EMRs is that they become silos. So my doctor has a wonderful database on me, but if I want to share that when I go to BC in a couple of weeks here, and if I fall off my perch in British Columbia, they have to start from fresh and probably have stuff faxed to them. But my point being is that EMRs should be talking to each other, but they're not. But here we are. We have cannabis. We have cannabis and this national database. What other medication? What other I can't even think of a word, because is a medication condition has a national database. And I was trying to ask him if he knows of anything. Like, does the MS,
No.
is there a national bank of MS patients? Is there, I don't know.
No, and this is a very cool thing. And it's not the EMR's fault. It's the fact that healthcare is provincial, not federal in Canada. But
Yes.
The reason I can segue into that is in Europe, because we get really cool info out of Europe, like around, about whatever, but lately it's been things like, around COVID, because like England or the UK has the national NHS, National Health Service, and they can pull out, you can go anywhere in England and it's connected, and they can pull out chunks of info from the whole. Well, the US is terrified of having anything linked, not even just state to state, town to town. So they are completely against anything being nationalized information wise. And Canada's not a lot better. But back to in North America, no, big national databases on stuff almost don't exist. But I want to throw in, so one of the things with EMRs is the docs originally were supposed to all put in ICD-9s, these fancy codes to say, this person has high cholesterol and this one has diabetes. It's a code to make it easier for a computer to find it and collate and do something with it. And sometimes they did it and sometimes they didn't. And sometimes the EMR would work well and sometimes it didn't. But what until now has been very difficult is the doctor's notes or the practitioner notes, the freehand, like typed in there, because it's basically a story, right? I saw Kirk and he had a big purple toe, and then he told me about his, his mother's dementia.
Charting. You talk about soap charting.
Exactly. And I was going to explain soap charting, but I don't do it very much. So Kirk, just quickly, what's a soap chart?
SOAP charting is just that, subjective information. Why the patient came in, what is the patient's complaint, what is the patient's story. The O is objective. So what do I see as a practitioner? What is my assessment? So the person comes in with a belly pain. I do a hands-on physical assessment, and that's my O. The A
Their
is
blood pressure, their and
well, but
and
my
A is
observation,
yeah.
and my observation, A is my assessment. So my assessment is, and I've said this before, you get a differential diagnosis when you see a doctor. The doctor never tells you what you got. He tells you what you don't have, and he goes through the negatives, negatives, negatives until he gets to, then it must be this. So you provide your differential diagnosis, meaning it could be this, it could be this, it could be this, and then you go with your plan. So SOAP, SOAP. And what is my plan? I plan this. So your plan should relate to everything the patient says and your assessment. What sometimes happens that becomes very difficult, and this is where I formed a real appreciation for the family docs, is that sometimes the objective and the subjective don't match. The patient comes in with a subjective story and you do your objective assessment. You go, there's something missing here. And that's where it becomes difficult because sometimes the patients are coming in hunting for meds, hunting for the narcotics, hunting, I've got severe pain, doc. So there are ways to elicit a pain response from a client, and you can do it, sir. I can't never say the word surreptitiously. I can do it secretly.
Surreptitiously.
Yeah, as I'm assessing and touching a patient, I can throw a little to see how they respond, and sometimes you don't get the response that you want. But so a SOAP chart. So in the
Yeah,
federal
but
system,
I'm going to jump in though.
yep,
The
yep,
reason we went on this rant and how it really does go back to who Dr. Thrul's project is, computers had a hard time reading narrative stuff.
yeah,
Taking
yeah.
a narrative like that, but now with AI, and he mentioned that now AI actually can look at narrative stuff like that and make sense of it. And more, so well, you could do that with a human, going and picking up. It could, a human can do a few, maybe a human can do 100. A human can't do 1,000 or 100,000 or 1,000,000 narrative reports. AI can. So that's one of the cool things about them using AI on this is if you get a bunch of these narrative reports, it can still pull out the useful information and try to categorize it.
Yeah. No, I found this a fascinating. I found this a fascinating project that they're working on. I could go on and on about medical records. I mean, moving from one province to another, the public health department was amazing, amazing. I got I got our immunization records for the family easy, and I went from one public health office to the other. The difficulty is working between doctor clinics, but that's a different story. So looking at this National Cannabis Study. There's a large team. It's out of the Johns Hopkins University, University Hospital. It's a study team. What I found interesting is that they seem to be psychologists and psychiatrists opposed to like their PhDs. There's not a lot of medical doctors on this team. It seems to me, unless there are some medical doctors buried in the PhD. This is truly an academic project, which makes it unique.
Yeah, no, and I think that's probably the place to start anyway. These are the researchers, these are the guys with the training and the stats and whatnot. But I also want to throw out there. So that was the good part of AI the AI should be able to sort of pull information out of narratives. The bad part, and he mentioned, is their survey has already been attacked by AI bots.
Yeah.
So because
Yeah.
you can be offered money to do some surveys, well, there's money to be made. So let's unleash a bot storm at the survey already. So they've locked that down. But like everything else, there's just every new technology. There's wonderful things it can do and terrible things. And yeah, the AI pulls out stuff from narrative, great. Attacks the whole damn survey, not so great.
Yeah, one of my mentors years and years ago always said to me, Kirk, this is great. We're problem solving. This is fantastic. You've come up with a solution, but now remember that all solutions come with their own problems. So you can come up with a wonderful idea, but you have to now critically think about what are the limitations of the solution. I don't know. when I went into this story and spent my 3 days studying it, I really can't see any disadvantage of it, except the fact, what I know about the United States is that no state likes feds. I mean, any novel I ever read, any TV show I ever watched, when there's state and federal issues, no one likes each other. So I can only imagine that there's going to be reluctance, because this looks like a national project, but it's funded out of, I think, gee whiz, I think it's funded out of Colorado. I don't have that reference in front of me, but I think I heard that because I listened to a couple other podcasts that this team was on, so I could listen to their story from other podcasters' perspectives, and I believe the funding's coming from Colorado, but yet it's John Hopkins, and I think they're in Massachusetts, right? They're in Boston,
Yeah,
aren't they? So
on the East Coast anyway. But I think the
yeah,
good part, like you said, we have our provincial silos, and Ottawa better not tell me anything about how to run my healthcare in Manitoba. I think there hopefully should be less reticence. Why this isn't run by the federal government. So the fact that it isn't being run by the government should hopefully make the states a little less worried about being involved.
yeah. Couple things I should, ranting about EMRs and stuff. A couple things I should pull out though that I thought was interesting that I'm going to explore further with other members of his team. We discovered that one of the members of his team is actually an alumni from the U of A, University of Alberta, and I'm going to investigate some of the stories that she did in Canada. But one of the things was the Cannabis Use Questionnaire. They have standardized a questionnaire for cannabis use, and they call it the CUQs. And what they hope to do is that if any researchers are out there that are doing cannabis related research, they have a standard set of questions that they want to encourage you to add to your survey so that consistencies are seen. And this is what interested me when I discovered this story, was that what these guys are doing is, I think, revolutionary from a perspective of understanding how cannabis affects people in a standard wise. So it's very academic. And it's basically across the spectrum. And go to our webpage, reefermed.ca. The links will be there, and it's all participatory. You can sit here and fill out the forms if you want, and add your information to their database. So it's a cool story.
Yeah, nope. Very, very cool. And sorry about the rants afterwards. But Dr. Thrall, that was great. And we wish the best to your team and this repository of information about cannabis. It's going to be fantastic. We're looking forward to looking at it afterwards and hearing some more research that come out of it. Yeah, keep us in the loop about how it goes, because I can't see anything but good things coming from this.
Yeah. We're Reefer Madness, the podcast. I'm looking for Canadian stories. As I said earlier, I have sent out many requests in the last couple of weeks I went to AI, Trevor, and I asked AI, I said, give me some Canadian research stories on cannabis. Like, what's happening with cannabis in Canada? And it didn't give me a lot. It gave me about 5 names and 5 universities and spaces, and 2 of the names were in the same university. So I sent out, I think, 4
Well,
or
the good
5.
news is our listeners are smarter than AI. So
Yeah,
listeners,
yeah,
you know of some Canadian cannabis research, tell us. We would
yeah.
love to include them in this. Our listeners are smarter than AI. Prove me right.
Yeah. No, let's get some Canadian content in this podcast, because it's not that we're not looking for it. It's just not coming our way. This is an American-centric story, but again, the information is relevant. And I think researchers in Canada who are doing cannabis research should look at their cannabis use questionnaire. So again, questions become standard. I mean, that's the thing about research, is keeping things standard so that they talk to each other, right? Let's,
Absolutely.
all right.
So, been another good one. Have a
Yeah.
good day, everybody. We'll talk to you next time.
Cheers.